So we now have going to have a panel. If I could have Misha and Alan and Barbara and Mikhail, and actually I'll ask you, Mark, as well, just to grab a chair and come up to the table here and grab some water if you like. And can I ask, do we have, what's the status of our other sites here? Are my friends at Duke still on? Yes, okay. What about KU Medicine at Wichita? Can you just tell us if you're still alive out there in Wichita?
Yes, we're live.
Great.
Check.
And what about the University of Missouri Center for Health Ethics? Anybody home? Okay, I guess we lost them. But no, so this is for the remote for Duke and in Wichita, you are you now have opportunity to ask questions of the speakers and panelists, and as you do here in the live audience. I've certainly got a number of questions I want to ask, but I'll give someone else a shot to start. Well, Mark, I've been behind the head. So how do you, is there any capacity, I guess is my question, or capability of the EHR and in aggregate these large data sets to capture subjective values-based information about patients that as a palliative medicine physician I'm very interested in to know because it's going to help me with treatment decisions?
My view would be that that's partly an implementation decision. So in a palliative care unit, if you create a structured document that's populated into your EHR, by definition, then you'll have that discrete data that lends itself to analysis after the fact. Currently, I think most documentation in those settings is not in a very granular, discrete format, but as you're given the opportunity to create forms that are very structured and render themselves towards analysis. So I don't necessarily think it's an EHR provider issue. It's largely an implementation opportunity. And then once that opportunity is exercised, then there will be a new set of...
Are these systems capable of accommodating information in different modes other than in I guess words? I mean, can you put
Sure.
pictures,
images? A key part of my work was related to structuring genomic information in the medical records. So, absolutely, there's it's beyond just text and words.
Right. Do we have anyone on the remote site that wants to come on? Not yet. Okay. Yes, sir. We've got several people here in the audience. This gentleman here and then the gentleman in the back. Mm-hmm. Oh, here. You just walked.
I know. He had his
he was first? Okay, great. Yes, sir. When you get the microphone.
Thank you. Just to follow up on your question, because that was a question that I posed to my institution as well, and it appeared to me that they had no idea of what question I was really asking. So when you ask, how do you really manage big data? Big data, quote unquote, is done by a big data management firm or company, i.e., excuse me, like IBM, being able to take your data that's in your electronic medical record or some other third-party management company and have your programmers program your database, whether it's Epic or Cerner or some other database. You program your data, and then you, quote unquote, give a big data firm the opportunity to manipulate that data so that it's in some usable form or format. But I think the question that you're asking and that we tend to ask tends to be a little bit more granular, and I think happens more at the programming level, at the hospital level.
I see. Okay. Thank you. We had a gentleman here, then a woman in front of him. Anyone over here? Would you, I don't know if you wanted to respond to that.
This is a different way of stating it.
Yeah. Okay. Yes.
If we look at individual databases, most of them have their own sense of control, their own boundaries, their own sense of privacy, And so they constitute a portfolio of conditions that go with that data set. You get into big data, you're combining a large number of these individual databases together, and I would be concerned that the maintenance of those same boundaries and controls gets dropped in the enthusiasm and fire of obtaining big data information. It's back, I think, in your veracity thing. You might be able to trace it back to the original database, but do you carry with it going forward all of those things which are stated or not stated in terms of privacy and control?
Yes, Bart, you want to?
Yeah, so I think the stewardship of data is an important topic for any organization, whether it's a private entity, a company, some of the ones named, or large academic organizations have comparably large-scale databases. And it's really a matter of the stewardship and the respect through which you treat that data and the trust that anybody providing data in will have in the organizations. The things like the business associates agreements and relationships that put some obligation for that proper stewardship are probably the closest things that are in place. Most of the examples I'm referring to are data scrubbed completely of the HIP identifiers and treated as limited data sets rather than requiring that consent be connected to those data points.
By the way, the panelists is free to ask each other questions.
Yeah. Yes, I'd just like to comment on that question. The consent issue was one that was raised with our commission because now in a lot of the big data sets, or the electronic medical record is being dumped in a lot of cases into a research database, which is I think what you're talking about here, and de-identified, but patients are usually asked for consent maybe when they're admitted to the hospital to have their data used or not, or when they're admitted for surgery, and it's at that time when you're signing consents to 100 things and may have no idea that you really consented to have your electronic medical record moved into a research database. And so there really are issues with that, but the de-identification is the piece that's probably key, and a lot of institutions are grappling with what kind of consent should be used. Is it enough to, some places don't even ask consent. They've decided it's not worth it to ask this sort of, if you will, fake consent or sort of consent by not understanding what you've consented to. So I don't know if you want to comment on the consent piece to this, but it's an issue.
I think there is a wide degree of variability in how each institution interprets their consent policies. I think that consenting towards research use of your de-identified data does, the general sense is that does not require individual level consent, and so places have the opportunity to extract data without requiring that. But there is a wide degree, I completely agree with the general sentiment that there is wide variability on how these things, and I love the label of the Bioethics Institute changing from Midwest to practical. I think when we're looking at practical issues, summarizing that variability and then using that to foster further discussion feels like a fruitful area.
Yes.
You, for Dr. Hoffman, you've talked about some of the really remarkable opportunities associated with big data analysis. Do you have examples of the misuse of big data with just wrong conclusions? I would think there's a tremendous opportunity for that also.
Sure, and I think when I look at translational medicine, so if you move too fast, the example that comes to mind from pharma is Vioxx. So if you release a drug too early based on misinterpretation of data or incomplete data, when you look in the drug safety area, there's probably some, quite a few good examples.
Yeah, and I can kind of vouch for that as well. There are numerous examples. We could be here all day talking about all the studies that have come out from big databases that led to erroneous conclusions. And I think, you know, there are many reasons for that. You know, you have to really know what it is that you're doing. You can't just mine data by saying, let's just look at these 250 things and figure out if any of them are statistically significant. You by default are going to find something that's statistically significant. And you know, whether it's real or not is an entirely different question. So, and I think this is the reason why we've gotten a lot of trouble with erroneous data making a big impact, where people actually change their practice of medicine based on data that's erroneous, is this coupling of big data at the same time in the information IT revolution with the fact that we live in a 24-hour news cycle, and this news gets immediately out and it gets sensationalized, where you find an association between a drug, for example, drug X, and some kind of an adverse event, and then all of a sudden it's on news everywhere and says, you know, this drug is killing people, and then the lawyers go out and start, you know, putting ads on, if you've been on drug X, please call us.
Yeah.
You know, you may be entitled to compensation, and then, you know, 5 years later, after, you know, gazillions of dollars being spent trying to do additional studies to understand whether this is actually true or not, it turns out it's not. And all of this was, you know, just a lot of headache and probably some harm done to some people for no good reason. So there is no question that there are some safeguards that can be placed around it, but there is no way to completely prevent it because, you know, a lot of it is about access. Who's got access to these big data? Are the people who are actually handling the data and doing research study have had formal studies and understand the difference between cause and effect relationship and the statistical association, and you know, trying to handle the data with enough respect and care to, you know, not draw erroneous conclusions before you actually confirm it through, you know, more rigorous data analysis. But I could give you just as many examples of hypotheses that were generated from big data that led to, you know, improvements in care and, you know, discoveries that really impacted. So it goes both ways.
Yeah. Back here.
Yeah, this may be a related question, but I'm wondering what are the ethical landmines that you could imagine are happening when we use population data to create and implement the clinical support systems?
I'm sorry, can you say this again? What about the clinical support systems?
What are the ethical landmines that we encounter in relying on population data to create and implement the clinical support systems or the algorithms?
I'm not a bioethicist. I mean, you know, I guess one, as you can tell from my talk, you know, I am a big believer into the fact that the large databases that are being collected for reasons. They're being collected to actually not just describe what we do, but to improve what we do. And it would be very poor use of resources if we didn't use it for that reason. You know, again, we live in a world where, in medicine, where you literally cannot take advantage of these complex models. Our mind doesn't work in that way, and without IT support at the point of care in these platforms, we're not going to be able to take use of them. There are, of course, as with anything, there are ethical considerations. You know, the patients who actually benefit from it may not be, and frequently will not be, the patients who contributed the data. You know, ACC and CDR, which is the database we used in the example I gave, is all de-identified. So when we use that data to try to come up with these models and then programs these models into support tools, we have no idea who it came from. And so there is certainly no way for us as clinicians to, you know, try to target it preferentially to people who contributed.
I'm wondering, though, if that isn't one of the ethical landmines, though. Because you said you have no way to figure out where, but Misha, I thought I heard you say in your talk that nothing is really de-identified. And then, you know, the other side of veracity is that you can get back to the data source and identify. So is this an issue? I mean, is this issue of the fact that you can ultimately, you have to be able to identify the source, and it gets back to the whole privacy conversation we had. But is that
I'm curious what Misha has to say about this. I mean, we've worked with data sets that were de-identified, and there are different degrees of de-identification. I can tell you, for example, that we worked with Cerner on their electronic health record database, and so it's literally, I mean, there were so many layers of de-identifications that they went through. It was very thoroughly thought through, and so when we analyzed the data, I mean, you know, it was very clear that it would require.
You have to be a really good hacker.
I guess. I mean, you know, even if you were determined,
Yeah.
I'm not sure, you know, how in the world you'd be able to do it because of how thoroughly de-identified it was. But I'm sure it may not be universal across all of the database. Some may be more de-identified than others.
Well, I think it comes back to how we sort of frame things. My belief is if we are to talk about risks of re-identification, we are obliged also to talk about benefits. So, you know, we have several anecdotes in the Personal Genome Project of people carrying high-risk alleles, and that information was made public, and someone said, hello, you have this. Anything that Yaniv Ehrlich can do notwithstanding, we know that there are lots of people who are presumptively anonymous. For example, there's someone in the HapMap project who carries a very high risk colon cancer allele, and unless we stand on our heads and violate the consent that that person signed, that person will never know that he or she carries that allele. You know, my concerns about big data have less to do with privacy violations and more about simply institutions trying to aggregate and monetize people's stuff in perpetuity, and it's nothing to do with cutting them in on the profits. It's just simply keeping them apprised at some minimal level as to what is going on, what is the status of this, and that can be an academic institution, it can be a company. You know, what happens if you have a biobank or a direct-to-consumer company and the company goes under? What becomes of that information?
Yeah, John, and then I think Mark, you wanted to, but yeah.
50 year. I serve on an IRB, and we've had two studies recently that have asked, in the consent process, asked for the patients to consent to the information being kept for 50 years. And it's a little disturbing. I mean, I don't know if it's disturbing, or it's just curious. It's like, what do they need it for 50 years unless this really is going to somehow, I think back to Misha's point.
Which Misha point?
The one we just made, that what is the purpose of the 50 years, and where does it go, and where does it housed, and how is it cared for, and how is it protected, and will it ever be re-identified?
So you're not against the 50 years per se, you just want more transparency about the...
Well, one of the studies we objected to the 50 years, and the other one we were just kind of scratching our heads. But I think for individual IRBs, and most of these folks are well-intended, you know, probably researchers themselves, in some cases it doesn't. We're just curious, what do they need it for 50 years? What's the purpose of that?
I have no idea. Yeah. The gentleman in the back wants to... Do you want to respond to this point? Yeah. Okay.
I sit on an IRB also as a clinician. The thought process is, and why not hold on to the tissue? So as we develop, you know, a more sophisticated testing, then the tissue or the sample then becomes available for testing in the future.
Right. Yeah. So you just don't want to potentially lose an opportunity, and 50 is probably arbitrary. Obviously arbitrary, but
I think it's problematic. I think, you know, we see copyright has been extended so that the heirs of Walt Disney can continue to profit from Mickey Mouse for another 75 years. But I think it begs the question as to what is the institution going to look like? Who is going to be the steward? And our IRB, and I think to its credit, raises eyebrows when people have protocols that say, you know, we're going to follow you for 10 years. Because the question inevitably comes up, well, you know, your R01 is going to be long expired in 10 years, and you might not be here. So what sorts of contingencies have you put in place to make this a realistic proposition?
Mikhail?
There is a bit of a counter-argument to that, which is if you look at experience of other countries, and Scandinavian countries is what I have in mind that have national registers, where, you know, so if you go to Norway, Sweden, or Denmark, every single time you get admitted to a hospital, you go see a doctor, you know, essentially the first time you encounter the healthcare system, your information, you know, you're in the register, and then you follow it for your lifetime. However long you live. So it could be not just 50 years, it could be 90 years, well, you know, as long as you live. So everyone receiving care in the country is in the national register. And now, you know, you could argue ethically that maybe that's not the right thing to do. I can tell you as a medical researcher, because I work with people in Sweden, that you can do things that we could never do in this country because of that database exists. You can actually understand on a country-wide level the interventions that you make, what impacts they're making on patient care. You can compare your results with other countries' results. You can do what's called randomized registry trials, where you can cut the cost of clinical trials when we test new treatments literally by 4 or 5-fold. And one of the reasons we don't have as many treatments available is because clinical trials are so expensive. It costs on average about $50,000 to recruit one patient in a clinical trial. You know, you could cut it by 5-fold because instead of following the patient, you know, in a very expensive infrastructure of a clinical trial, you can follow them in a register infrastructure that's already established and see if they had another heart attack or if they died. So there are definitely downsides because you're exposed for your entire lifetime, you know, in some government database that somebody's monitoring, but at the same time there are clearly and undeniably huge benefits as well. So it's all the question of, as a society, what are we willing, you know, what are we willing to compromise to get those benefits?
So have we not gone to for Americans? Is that right?
There are many reasons why. Mainly, we don't have this because the healthcare system is a lot more fragmented, and there are, you know, good and bad things about that. You know, but yeah, it's essentially it's a social contract in Scandinavian countries where you agree, you know, for presumably, as a country, they agreed for this to happen. I'm not sure if there is, I actually don't think there is individualized consent for every patient. I think it's just a social contract that the citizens have with their government. That's what they're going to do. You know, and again, without passing judgment, you know, whether that's right or wrong, it's just to say that there are clearly issues with that, and there are also clearly benefits.
So there were actually, I think in Science several years ago, Francis Collins, when he was still NHGRI director, had proposed a large-scale cohort study of 500,000 people, something akin to the UK Biobank. And I think it didn't go anywhere primarily for financial and budgetary reasons. But there was a whole series of town halls across the country asking people what they thought about this idea. And, you know, what are you afraid of? What are you excited about? And the general response was, this sounds great, and yes, I would like my individual results back.
I think to loop back to your question about the ethical impact of using population data, so on the one hand, when you have millions of data points, you dilute out the personal details of any single patient that might inform that patient's care. I think in the U.S., you know, I appreciated Mikhail's comments about the scrubbing of the Cerner data set, the cost of some of the, so to fully comply with HIPAA, you remove all of the identifiers that you'd need to match across data sources. So claims data gives you the best longitudinal, family practice to the hospital picture, but you can't merge that because you've removed all of the potential hooks to connect those. So that's the, there's some costs to that in other national, and then there's the lack of a national identifier that, even Social Security number doesn't work. If you could use it, it still wouldn't work. So there, those are some of the trade-offs that are made.
We have one last question before, yes.
Yes, Cindy Russell from University of Missouri in Kansas City. I want to applaud the diversity of the presentations this morning. I thought it was fabulous. But one of the areas I'm wondering about is what do the panels see in terms of the future for genetics and psychosocial issues and behavioral issues? We've really talked a lot about physiologic diseases, but my area is transplantation. So, genetics is really looking at the pharmacogenetics and so forth with our patients. But what about the patients that are non-adherent with their medications? Do you see in the future that perhaps we'll have some sort of genetic marker for poor behavior, or on the other hand, excellent behavior? And how do you think that will happen, and how will that play into this whole ethical issue?
Yeah. Anyone?
I'm nervous to address that, but I will, because I think it's a really nice point. My job at Wisconsin is half in a legal studies program. We do a lot of criminal justice and a lot of stuff about criminalization of various sorts of behaviors and criminal procedure and investigations into people who are likely to engage in antisocial or criminal behavior. And that's the kind of worry that, the kind of background condition worry about privacy that motivated part of what I was trying to argue in my talk, is that, look, that's really enticing kind of data to go after if we're worried about antisocial behavior. And there may be surely there's some social benefits to that. But yeah, I think that's particularly worrisome. I agree, and I think it's we tend to give a lot of deference to security and law enforcement and other sorts of and similar sorts of entities, and that kind of data might be particularly useful or attractive. They are. That's right.
Okay, just one last quick comment.
I understand the question. I also take a different approach to it, that non-compliance or poor compliance isn't necessarily a genetic marker. It could be a social marker, which is something you're not going to pick up in any database. People often make decisions about adherence or non-adherence, poor adherence based upon economic issues. So, always finding that in a genetic database, I don't think is also the right target.
But, yeah, I mean, this actually opens up a really interesting, larger question that we can't get into now, but it's, I think, really, really fascinating. So we're going to break for lunch. You had Barbara?
I was just going to make a comment. The next issue that the Commission is taking up is the BRAIN program that the federal government funded. And this is going to be the whole criminology piece, I think, is going to come up in that, as well as some of the social issues, because clearly scans and things like that may be better than whole genome sequencing, for instance, at looking at some of those social issues.
Yeah, there's actually a fascinating series on PBS right now called Brains on Trial, where they're looking at the impact of neuroscience on jurisprudence and legal processes. It raises, I mean, there's some profound ethical questions about, what is privacy? What are your private thoughts and what are not? And self-incrimination and not. Really interesting stuff. So yeah, I agree with you there. Well, great morning. I want to thank the panelists. Can we all give them a speakers this morning a hand. You folks were great. The questions and discussions were great. Before we break for lunch, I just need to remind you to fill out your evaluation forms that are in your packet. And for the physicians who are applying for CME, there's an additional blue form that you need to fill out to get CME. And we are going to have a half hour for lunch.